Thank you so much also for allowing us to be here. Now, it gives me great pleasure to turn this over to our amazing presenters and first moderator for the day, NCD Council Member and Chair of the Entitlements Committee, Mr. Ari Newman.
Good morning. Can you all hear me? Excellent.
Yeah.
Well, once again, thank you so much for having us here in Wisconsin. It's a pleasure to continue the Council's work with regards to the topic of Medicaid managed care and people with disabilities in your fine state. I'm going to begin the morning with a broad overview of some of the Council's recommendations with regards to Medicaid managed care. And to give you a sense of our orientation around these issues, the Council has been exploring the topic of Medicaid managed care and its potential impacts, both positive and negative, on people with disabilities since 2011, with our first policy outputs on this topic taking place in 2012 and 2013. We've conducted regional forums in obviously Kansas, but also Tallahassee, California, New York, Pennsylvania, and Baton Rouge, and a wide variety of other parts of the country. And really our goal here, and if we could just ask the folks on the phone to mute themselves, please. And our goal here is to really give a sense in a comprehensive way as to what Medicaid managed care is and what are both the risks and potential benefits of Medicaid managed care as a payment delivery model for services delivered to people with disabilities. So I'll begin with slide 2 that just gives a little bit of background on who NCD is as a federal agency. We are an independent federal agency, which means that we have the power to issue recommendations on everything and make requirements on nothing. We serve as the federal government's think tank on disability policy. And while a number of our recommendations on Medicaid managed care have been adopted by the entity with primary regulatory authority over the Medicaid program, the Center for Medicare and Medicaid Services, I do want to be upfront as to our role, which is predominantly advisory on these issues. We have 9 members appointed by the President and Congress, and we advise Congress and the executive branch on the broad scope of disability policy, ranging from education to transportation to healthcare to long-term services and supports. We've chosen to make Medicaid managed care a high area of emphasis for the Council, in part because of the significant impact it can have on people with disabilities. And so out of the broad scope of disability policy, in the last several years, managed care has represented a disproportionate focus of our efforts. And I'm going to talk a little bit, and let's go to slide 3 now, as to why that is. So managed care is not a new concept by any stretch of the imagination. And folks here in Wisconsin should be very aware of that, given that discussions here have predominantly focused on moving from one existing model of managed care to a new model of managed care. Managed care can mean many different things in different states. Some states operate managed care frameworks in which the state serves as its own managed care organization. Some states operate managed care frameworks in which nonprofit organizations serve as managed care organizations, and some states operate managed care frameworks in which national insurance companies serve as managed care organizations. And in fact, many states operate hybrids of all of the above. The majority of Medicaid beneficiaries today have some component of their Medicaid benefit delivered through a managed care delivery framework. But if we look at the early history of managed care, we notice a couple of things that are a little bit different from how the conversation on Medicaid managed care is going nationally today. First, historically, managed care was utilized predominantly for acute care services, services delivered by a primary care physician or a specialist that were very clearly medical in nature. And managed care was focused initially predominantly on non-disabled, low-income adults. And that really comes out of the fact that, the essential nature of a managed care relationship, or the most common managed care relationship, capitated payments, providing an average payment to a managed care organization that equals the anticipated average payment for serving the people within that managed care population it's much easier to calculate with the non-disabled adult population than it has been with regards to people with disabilities or people with various chronic illnesses or special health care needs. And again, because of that, the cost savings to be realized by managed care were really looked at as things that would materialize predominantly because of improved care coordination and various efforts at preventative care that would be materializing within the life of a 3 to 5 year managed care contract. Essentially, with the non-disabled low-income adult population, it's much easier to realize those cost savings predominantly through that prism of preventative care and improved care coordination. But increasingly over the last 10 years, we've started to see managed care shift to cover new populations, in part as a result of the pressure to cut state budgets, in part as a result of a recognition that care coordination does legitimately need to be improved in many parts of the country for long-term services and supports and people who experience disabilities or chronic health problems. And there are a couple of significant differences with regards to delivering managed care for people with disabilities or people with chronic health conditions as compared to the previous population. One is very straightforward. When talking about supporting people with disabilities, managed care organizations need expertise on long-term services and supports. And this is really a very different kind of service as compared to acute care. And there are often, as we're going to be discussing, a number of very real risks when an organization that is predominantly used to interfacing with doctors and hospitals suddenly faces the challenge of understanding how to interface with a long-term services and supports infrastructure, with home and community-based service providers, and understand concepts like self-direction, supported employment, supported living, person-centered planning, and so on and such forth. But one of the other characteristics that really materializes in the shift to managed long-term services and supports is that to a significant degree, even within fee-for-service Medicaid, managed long-term services and supports already experience a significant amount of care coordination. So the cost savings associated with Medicaid managed care aren't as likely to come out of just applying additional preventative care or care coordination. Instead, generally with managed long-term services and supports, cost savings materialize by the managed care organization achieving successes in moving away from legacy infrastructure. And in fact, some of the states that have had the most success with managed care have done so in part by utilizing the managed care contract as a framework for moving people out of nursing homes or out of institutions, or increasing the number of people with disabilities in integrated employment, and really requiring managed care organizations, on pain of financial penalty and with the offer of financial reward, to make progress in accomplishing these goals. And one of the other issues that materializes there, of course, is that often the infrastructure investment required to achieve success within the context of moving away from legacy infrastructure will not realize cost savings during the life of a typical 3 to 5 year managed care contract. Some of those returns will accrue to the residents of that state far beyond that 3 to 5 year contract. And so it becomes important to build into the managed care organizations incentives, whether that managed care organization is a for-profit, nonprofit, or state entity, a strong incentive to look beyond just the life of a particular contract and to realize those returns after a 3 to 5 year period. So if we can go to the next slide, I'm going to highlight 7 broad areas in which managed care and people with disabilities interact, and in which we believe states seeking to design a managed care system should take into account before moving forward with a contracting process or really even an RFP. These are designed and really emerge out of our national, and if we could just ask the folks on the phone to mute themselves again, or if we could take the phone line off of speaker until we are ready for the Q&A, that would be great. Thank you. This is really designed to reflect our experience at the national level rather than any particular circumstance specific to Wisconsin. And it really comes out of the need for...
Hi. Friends on the phone? Hi, can you hear me? Great. I need all of us to be good global citizens to each other. We have to ask that you mute your line using *6. Otherwise, nobody, not those of us in person and not those of you on the line, will be able to hear the presentation. Please mute your phone and or please take your phone off a speaker until we have our question and answer period. Thank you so much. I'm sorry. All right, please continue.
So we're going to highlight a couple of major areas in which states need to take into account. The first is community integration. And again, managed care organizations, managed care, if we can move to the next slide, managed care can be a tool to move people into the community. Given that generally speaking, home and community-based services are more cost-effective than institutional services, if a managed care organization has a capitated rate structure that incentivizes community living, that either pays the managed care organization the same amount for the same individual, whether that person is in the community or in an institution, or pays more for a community-based placement, then that managed care organization can have an incentive to move people out of nursing homes and out of intermediate care facilities and into home and community-based environments. One of the risks associated with managed care frameworks that are poorly designed is many states have carved out the institutional benefit within their managed care system. And what that's meant is that you have a dynamic in which, say, a state's home and community-based services for people with developmental disabilities are in managed care, but all are part of the state's intermediate care facilities are in fee-for-service. Or a state's home and community-based services for seniors are in managed care, but all are part of their nursing homes are in fee-for-service. And that creates a really problematic incentive for the MCO, because what it means is that the MCO then is motivated to shift into an institutional setting anybody whose costs are higher than their average capitated payment. For managed care to work as a tool for community integration and to avoid being an active obstacle to community integration, the institutional benefits for a particular population whose community benefits are being moved into managed care must also be moved into managed care. And really avoiding these institutional carve-outs is one of the Council's strongest recommendations on this topic. The question of how we define community integration is also very important. Many of you are aware that CMS has new requirements that every state will be required to meet by 2019 with regards to what is and what is not home and community-based services. These must be written into the managed care contract, and MCOs must be held accountable not only for shifting people out of the broad funding categories of SNF or ICF or IMD into HCBS, but in making progress on community integration within the HCBS waiver, such as moving people out of group homes and into supported living, or out of sheltered workshops and segregated day programs into integrated employment or integrated day activities. And again, as part and parcel of this, we need to avoid the medicalization of services, recognizing that you're often going to have a dynamic in which an MCO is coming in that may have limited prior experience with long-term services and supports, and ensure that crucial things like self-direction and person-centered planning are maintained. Provider network adequacy. Now, the typical model with regards to managed care is that an insurance company or another managed care organization contracts with a certain number of providers in order to deliver their services. And so all of a sudden you have a situation where providers need to learn a drastically new set of skills around negotiating with managed care organizations, particularly if there are multiple MCOs within their area, around arranging billing arrangements that may be different across multiple different MCOs. This can often place small and non-traditional providers at risk, and we know that in the home and community-based service system, non-traditional providers have historically been a source of disproportionate innovation. And so some states have adopted a variety of models to try and protect against this. Many states require MCOs coming to the area to contract with an existing scope of providers. Some states are requiring MCOs operating in an area to agree on a standardized billing infrastructure to save small providers the administrative costs of suddenly moving from one entity that they build to 3 or 4 or 5 with potentially different arrangements. There are a variety of efforts to provide technical assistance to providers and to MCOs with regards to increasing their MLTSS knowledge. But critically, states have to assess the degree to which a particular population's provider network is ready to move into managed care prior to making that shift. And if they're not ready, they need to be willing to delay that shift for that particular population, recognizing that different populations may be ready at different times or may be a better or a worse fit for a particular managed care infrastructure. I want to highlight perhaps the most important topic in Medicaid managed care, which is the issue of accountability. We are contracting with external entities to manage a state's publicly funded programs. And so the obvious question that should emerge here is, how do we know whether or not they are doing a good job? And when we talk about acute care, there's a wide range of quality measures that have been developed here relating to, have people been in an emergency room in the last 12 months? Do people have diabetes? Do people, et cetera, et cetera? But when we're talking about long-term services and supports, the topic of quality measurement is still relatively new. And states need to build quality measures that they can write into the managed care contract and hold MCOs accountable to from a financial perspective that will relate to the needs of people with disabilities. One of the best practices models we've seen in the developmental disability sphere around this is the National Core Indicators Project. It's currently being adapted to the aging and physical disability space. There have also been a variety of efforts to utilize things like rates of integrated employment, rates of removal from nursing homes and shift into community-based services, rates of self-direction, which is one particular model that I'm fond of because not only does it ensure the preservation of self-direction, it creates a financial incentive for MCOs to actively recruit and educate people about self-direction as an option. Tennessee has adopted that in their aging and physical disability system. And other measures that, again, can be built into the managed care framework. We were in Kansas. One of the things we discovered is that Kansas is withholding about 5% of their payments to MCOs in order to evaluate whether or not they are meeting these outcome measures and rewarding those payments predominantly on the basis of those kind of quality considerations. I'm going to briefly highlight employment outcomes. I think folks in Wisconsin are very familiar with how important this is. Generally speaking, we want to make sure that managed care organizations recognize, and they may not, given that managed care is particularly new in the developmental disability space, that suddenly they will be in the business of paying for employment services, and that in fact Medicaid is a major payer here. Supported employment is one of those services that's cost-effective over time, but the real ROI on it may only materialize after that 3 to 5 year period in the managed care contract. So it really has to be spelled out that the MCO will be held accountable for these kinds of things. And given all of the work that's been done previously, getting state DD agencies and other aspects of Medicaid to interact with voc rehab and the public school system, we want to ensure that there's a mechanism for managed care organizations to continue that interaction and continue to be held responsible for interfaces with non-Medicaid infrastructure. Finally, I'll add that we believe very strongly in making available data around employment in a publicly accessible way that disaggregates by region, that disaggregates by provider, and critically also disaggregates by managed care organization. Consumers should be able to see that people being served by managed care organization A have better outcomes in employment than people being served by managed care organization B, and that data should be made available not a year or two after the year in question, but in as much as possible in real time on a quarterly or a biannual basis. Managed care really includes, and employment is one example of this, a more diverse benefit package than acute care services. Family support services are another example in which the cost of not providing these things might not accrue in the life of a managed care contract, but there's a tremendous human and eventual financial cost here as well. Families will, and I think this is really to their credit, hold on for as long as possible before sending a relative into a residential service environment, whether that's an institution, a nursing home, or a group home. It's very important for us to recognize that A, we have a human obligation to support families, but B, there's a financial incentive because a family is going to be able to provide support in the home for much longer and keep somebody out of a much lower quality and much more expensive residential service provision environment if family support is provided. We want to make sure that if a family is going to be likely to give out around year 6, that a managed care organization doesn't have anything within its contract that would allow them to effectively say, that's outside of our contracted period, it's not our problem. State managerial capacity. This is an incredibly complicated system that requires strong oversight on the part of the state. We need to understand managed care not as privatization of Medicaid. If your state policymakers see it as privatizing Medicaid, then they're probably not going to be doing it effectively, but as contracting for a particular kind of service on the part of the managed care organization. And as with any contract, the entity that is doing the contracting needs to understand the work that is being done and have a clear knowledge about the population in question, a clear ability to track outcome measures, and a clear ability to monitor things like due process, grievance and appeals procedures, and other things that help retain the broader knowledge base on the populations being served and allow them to serve the managed care infrastructure in an effective way. We've often held up Wisconsin's ombudsman system as a model for other states to follow by virtue of the fact that you require a clear ratio of ombudsmen to beneficiaries. And that's something we often don't see in other states. In one state we went to, there was precisely 1.5 FTE for the entire state's Medicaid program devoted to ombudsman services. Generally speaking, as I'm sure heroic that 1.5 individuals were going to be, that's not an effective means of managing a managed care program. Next slide.
Yes, good afternoon. Our friends on the phone, thank you so much for joining us. If you could please place your line on mute using *6 and/or place your phone off of speaker, it would be greatly appreciated to reduce background noise so that everybody here in person and on the line can hear the forum. Thank you.
And again, different populations should be approached differently. Prior to moving not only the state as a whole, but a particular population within the state must conduct a readiness assessment and determine an appropriate phase-in schedule for managed care. And depending on the level of provider adequacy, competence with managed care, MCO competency with the particular population, and most importantly, the level of engagement that's happened with self-advocates and families on the part of the state and on the part of the MCO, whether or not a population should be phased in or when they should be phased in is very, very different. So I've highlighted a couple of basic questions here that relate to what your state should be thinking about on managed care. Many of these things are reflected within the Council's documents on this topic and are available at ncd.gov in our healthcare section. In our healthcare section, we don't have that.
Oh, okay. I'm sorry. I thought we did.
In our healthcare section in 2012 and 2013 in particular. But we really want to highlight at a broad level stakeholder engagement, a clear accountability mechanism, both in terms of quality and questions like grievances and appeals, and a strong understanding as to what the model is for cost savings and quality improvement. Too many states have this idea that step A is managed care, and step C is massive cost savings and quality improvement, and somewhere step B has a question mark on it and they'll figure it out later. That doesn't work. And we really want to ensure that states do not adopt that kind of framework. I'm just going to very briefly highlight the new rule that CMS has just proposed on Medicaid managed care, because it's probably going to be relevant to what Wisconsin ends up doing in the future and really what happens in general. The rule establishes a number of important components that managed care organizations will be required to be held accountable to in the event that this rule is moved into final form. The first is it sets a minimum of an 85% medical loss ratio. That means that MCOs must spend at least 85% of the funds that flow into them on medical care for the people who are being served. This is very similar to the requirements the Affordable Care Act placed on private insurance. States can set a much higher medical loss ratio, and states can determine different rules as to what does and what does not count as a medical expense. This is quite important in part because states want to ensure that MCOs are spending their money on their beneficiaries, but they also don't want to disincentivize spending money on things that are not medical but may have an impact on medical outcomes. If an MCO is spending money on housing navigator services, for example, to help people find access to housing that's affordable and accessible to get them out of nursing homes, the state needs to very clearly articulate if that's going to count towards the medical loss ratio to avoid creating a disincentive for those kinds of social determinants. This rule requires clear appeals and grievance standards, clear readiness review standards. It creates a structure for engaging stakeholders regularly in monitoring and oversight with regards to managed long-term services and supports. And it articulates a plan for a quality rating system for managed care organizations that will be aligned with the broader rating system for private insurance. The rule articulates that managed long-term services and supports have to be consistent with the ADA and Olmstead, and particularly articulates, although it doesn't get into as much detail as we would like, that payment methodologies have to reflect goals to incentivize both better health and community integration. It states that enrollees have a right to a single point of contact on complaints and concerns and assistance with enrolling, disenrollment, and appeals. It requires that managed long-term services and supports have providers meet the person-centered planning requirements of the new settings rule. And I want to highlight in particular, it changes the definition of medical necessity and particularly highlights the idea that enrollees should have the opportunity to access the benefits of community living, and funds spent towards those ends will now meet, under this rule, the definition of medical necessity. And that's a very important innovation for the Medicaid system as a whole, because how medical necessity is defined is one of the most difficult things that often comes up in state negotiations around applying managed care frameworks. And then finally, the rule also sets some time and distance standards. It requires states to set time and distance standards for provider network adequacy. That means stating things like people should not have to travel more than X number of hours or Y number of distance in order to access a supported employment or a supported living or another kind of service provider. And it requires that enrollees be allowed to disenroll from managed care at any time, or if a state is not allowing disenrollment, that they be allowed to change managed care plans whenever terminating a provider from a managed care plan would result in a disruption to that person's residence or to their employment. I think we're coming up at the end of our time, but I want to see if we have the opportunity to take one or two questions from the audience. And I'll just say very briefly here, the Council's orientation to managed care is neither positive nor negative, but we believe that if you do it, you should do it right. Like splitting the atom, managed care can be used for great good or great evil, and you want to be very, very careful when you're doing it. Do we have any questions from the audience? Please come up to the microphone.
Can we get a copy of your outline?
We'll send all of that out.
Yes, I just wanted to let everybody know for any of the PowerPoints that are presented today that I will send them out to those of you that RSVP'd. I have your emails. If you did not and you're here and would like the PowerPoints, just write down your email or your business card. Give me your business card. I'll make sure you get the PowerPoints.
Do we have any other questions? Up there in the front. So medical underwriting was prohibited in private insurance within the context of the Affordable Care Act. So we've had a fairly significant development in that regard. In Medicaid managed care, because the state is the payer rather than an individual, then the state is just determining the costs associated with shifting a population into managed care. And in fact, we want the state to be paying the MCO more for populations that would cost more to serve. But after the Affordable Care Act, it's no longer possible for private insurers in the private non-Medicaid system to engage in medical underwriting. That's correct. And can we take one more question from the audience? And we'll take all the way in the back, if you don't mind, sir. You, yes.
Examples of states that have implemented managed this population. Examples of contracts that Wisconsin administrators should look at that have incorporated many of the principles that you're describing.
So I'll just start by repeating the question. Do we have examples of states that have done this well? Well, first, in other states, we've referenced Wisconsin's aspects of Wisconsin's existing system. So certainly that's been relevant to the discussion, and I would encourage you to be able to adapt what is already working in your state to allow it to continue to work. I think there are a few different models that different states have adopted. We saw some promising contract language in Florida, and certainly we can share that with you. Arizona has a fairly good example as to how to approach the operation of a state MCO over a long period of time. We've also seen some very strong contract language in a number of other states, particularly around quality measures, some of which have been adopted particularly for the dual eligible demonstrations. Much of this is reflected within the council's reports, particularly in 2012
Ari,
and 2013.
that might also be a good question to ask the speaker from CMS.
And with that excellent segue, I'd like to hand things over to my esteemed colleague Clyde Terry and move to our next presentation. Thank you all for joining us.
Thank you, Ari.
Okay, is this on?
Yes.
Okay, I guess I can be heard, even though I can't hear me. Thank you, Ari, and indeed, thank you all for